Electrode application. Last week's talk on the sleep lab equipment focused more on the technology that we utilize in the sleep lab, on all the different pieces of equipment that we utilize. This talk will be more on specifically how we apply all of that equipment. So let's start with how we apply the head wires. We utilize the International 1020 electrode system. It was developed in 1949 by Dr. Jasper, and it's essentially a standard measurement for how we apply the electrodes on the head for recording the EEGs. In the name, it's international, meaning that you could have a sleep study or an EEG done in New York, California, Canada, Italy, wherever. Your head is going to be measured exactly the same way to apply those electrodes to the scalp. That's for reproducibility of a study. We know that especially patients that have a history of epilepsy that need these types of studies done, it's tracking their progress, their disease progression, all of that, and they don't have to keep going to the same exact lab or same exact facility every single time. It's for standardization among the tests, so that we know what we're looking at, we know what area of the brain that we're recording it over. We use anatomical features to be able to find where we're applying the electrodes. Four anatomical features are the kind of cornerstone for how we start to apply the electrodes. We measure distances between these anatomical features or anatomical landmarks, and then utilize those measurements, distance between one anatomical landmark to the next, and find the percentages, break up that measurement into percentages. 10%, 20% are the most common, which is why it's called the 10-20 system. So every head is a different size, a different shape, and that comes into play. So you utilize percentages of this measurement, or you're going to then go 10% up to find this placement of this electrode versus 4 centimeters, and because not every head is the same size, so using percentages makes it more accurate to find the areas of the brain that we want to have our electrodes placed over. It's a systematic way that the electrodes are named. Each electrode point is named with a letter and a number. The letter represents the area of the brain that the electrode is over, typical whichever lobe it is, F for frontal, occipital, P for parietal, T for temporal, C is for the central area, which it represents the area of the central sulcus, which is the separation from the frontal lobe to the parietal lobe. It's also where our motor and sensory strips are located on our brain. The numbers represent what side of the brain it's on. Odd numbers are always on the left. Right side are always even numbers. The closer to the midline that the number is, the lower the number is, and as it gets farther away from that midline, the higher the number it is. And Z represents that the electrode is on the midline itself. So here is the midline, so all of the electrodes here are labeled with a Z. The first identifying letter is the area of the brain that it's over. Frontal lobe, anterior frontal, frontal polar, central, parietal, and then if you notice, left side's all the odd numbers, right side's all the even numbers, and as you get further away from the midline, the numbers go up so higher the number, the further away from midline it is. This is an extended version of the 21 lead system. Typically for EEG, we do 21 points. For sleep, we do even less than that, which is beautiful. But what's really nice about the 10-20 system is that it has the ability to add on more. So this is like a very extended version. So for instance, if you have somebody that has an abnormality, something going on in a certain area of the brain, you could add even more electrodes to that area to better visualize where the abnormality might be originating from. And it's a very systematic way of applying electrodes that you easily can add on more electrodes in a very kind of programmable way. In a full EEG, as many as 256 electrodes could be used. That's a lot. So for sleep, though, we use a much abbreviated version. Only about 6 electrode sites are used for the scalp to pick up actual brain waves, and then we apply 4 additional ones as reference or ground electrodes. So they're the ones that kind of the electrodes are referenced to, and they kind of go in an inactive area. The American Academy of Sleep Medicine recommends that we apply these following electrodes for a standard sleep study, and that's where they're placed. You got your F3, F4, C3, CZ, C4, O1, O2, A1, A2. You'll also see that A1 and A2 are sometimes referred to as M1, M2. M1 and M2 are actually the more updated nomenclature for these positions. A1 and A2 is a more of a dated version, but you might still see it written that way, which is why I give them both to you. So how we apply the electrodes is, remember, we utilize 4 anatomical landmarks. So that's the first thing that you have to do when you're measuring for a head, is find the anatomical landmarks that we utilize: the Nasion, the Inion, and the preauricular points. The Nasion is the bridge of the nose. It's the indentation between the forehead and the bridge of the nose. Typically, it's kind of just between or just below where your eyebrows might come together, where your nose indents before it comes up to the forehead. The Inion is on the back of the head, and it's kind of this bump on the back of your head. It's where the skull bone that kind of ridges before it comes back in. If you put your hand on your back of your head, you'll feel a ridge, and if you don't, what you want to do is kind of put your hand there slightly and move your head up and down a few times, and oftentimes that ridge will kind of find itself on your finger. The Inion is probably the most difficult to locate of all the 4 anatomical landmarks, because some people have really flat back of their heads, some people have kind of really bumpy back of their heads, so it's easy to kind of confuse that point for just a bump on the skull. It's one of those things that it's going to take some practice and everything just to get used to it. If you're absolutely questioning where the Inion is, one trick is to find your preauricular points, and the preauricular points are the ridges in between in front of your ear. Typically, it's kind of very close to the tragus of the ear, which is this little ridge right here. And it's usually oftentimes kind of right in front, but there's usually a little divot kind of right in front of the ear. An easy way to find it is if you put your hands in front of your ear and then open and close your mouth a few times, you'll feel this indentation. When you do that, that's the preauricular point. Fairly easy to find. Once you've found your preauricular point, and if you're having trouble finding your Inion, oftentimes the Inion is at about the same level as the preauricular points if you're looking at the skull. So, it's kind of the same level. Not a hard and fast rule, but if you absolutely are having difficulty finding the Inion, that's a trick to it that you can try, is find the preauricular points and then kind of trace it back, and it's very similar to about that same level as where the preauricular points are. So what you'll need to measure the head is you'll need your measuring tape, and we're using the centimeter side for it. Wax pencil. Most labs utilize a red color because it's bright. It'll show up on the scalp. If the wax pencil gets dried out, you want to try to moisten it a little bit. So I usually will you're going to have your cart set up, so a really good little tip is to actually dip the tip of the pencil in the new prep, the little the electrolyte, so it kind of re-moistens the pencil and makes the marks a lot brighter. Hair clips are optional. Depends if you have somebody that has hair, and B, whether or not hair clips make it easier for you, or if you find it makes it more of a challenge. But hair is something that you're going to have to learn how to work with. I'll teach you different tricks to utilize and move the hair out of the way, but you might find that utilizing hair clips takes more time than it's worth. Something it's just you're going to have to pick up with experience. So when you first thing you got to do to apply your electrodes is you're going to find your 4 anatomical landmarks. The first absolute measurement you're going to do is from nasien to inion, which is the bridge of the nose all the way back to that ridge on the back of the head, and you're going to go straight back. The one thing you're going to have to learn how to do is kind of stretch your hands along the measuring tape to keep it steady, so that way, you know, your zero line stays lined up with where you want it to be, and it holds the measuring tape in place because you're going to make marks along the measuring tape. And then the other thing too with it is you want to make sure that it stays flat, it doesn't slip, especially accurate measurements are so important for the accuracy of the test that we're doing. So the first thing you're going to do is measure nasien to inion, and then remember the 10-20 system operates off of percentages. So whenever I say 10%, 20%, it's always of the entire measurement, the entire anatomic to anatomic measurement, not a percentage of a percentage. But what you're going to do is measure nasien to inion. You're going to get that measurement, and then you're going to figure out what 10% of that measurement is, which is really just, you know, moving the decimal point over. So if nasien to inion was 36 centimeters, 10% is 3.6, and you'll measure that 10% up from the anatomical landmark, the nasien, and then you'll go in the back and you'll measure 10% up from the anatomical mark in the back, which is from the inion, and make the first mark for FPZ, and this is OZ right here. Once you have that, what you're going to do is you're going to measure halfway between nasien and inion. And again, you don't even have to move your measuring tape. If you learn how to like stretch and hold it in place, you can make a lot of these marks while you're just holding the measuring tape in place. Make a mark at the halfway mark, and then you're also going to make a mark for FZ, which can be done a few different ways. So again, this is a very systematic system. If you notice, it's 10%, 10%, and then all of these 4 segments are 20% apart. So what you can do is 20% of the nasien to inion measurement. You could measure down from CZ or up from FPZ. We're going to talk about a lot of different methods. I know a lot of people, and I'm gonna go through in lab the exact way that I recommend that you learn how to measure and do the math, because there's the way that I teach you guys is there's going to be a lot of opportunities to double check your work as you go, because you're going to, as we move on measuring the head, certain measurements are based off of where a previous mark was made. So for instance, if you mess up where that mark was made, it's going to keep snowballing and mess up even further measurements and marks. So it's important to double check your work as you go, so that as you're marking and figuring out the points, that they're accurate. The next measurement you're going to do is preauricular to preauricular, and you're bringing your measure, and the reason why we're going in a specific order is because you have to bring your measuring tape through the first line that you made for CZ, so this halfway mark between the nasien and the inion. You have to, and with the it looks like a straight line here because it's a picture, a 2D picture, but on the actual scalp, you're going to find that you're going to have to really bend, and it's not a straight line going from preauricular to preauricular, so it's important to know where your CZ is to bend your measuring tape and bring it through that mark. Make another halfway between this measurement and this measurement, and it will cross mark your CZ. Cross mark meaning X marks the spot. You found it on the vertical plane and you found it on the horizontal plane. So no point is complete until it's been cross marked, until you found it both vertically and horizontally and those lines meet. So that mark right there is the absolute tippy top of the head, the CZ. From there, you're going to measure up 10% of the preauricular to preauricular on each side to make your first mark for T3 and T4. And then what you're going to do is find your measurement for C3 and C4. So again, this is 10% from A1 to T3, 10% from T4 to A2, so which means each of these different segments is 20% of the entire measurement from preauricular to preauricular. So what you're going to do is from the CZ measure 20% of the preauricular to preauricular measurement down to make your first mark for C3, and then again on the other side to make your first mark for C4. Here's kind of a picture of the head that shows all the different percentages. Third measurement you're going to do is the circumference, and where you measure the circumference is going to change what the actual measurement is. So we've made, from each anatomical landmark, you've made a 10% up when you're doing those marks, and that's where you're going to line up your circumferential mark in order to kind of figure out where on the head you're measuring for the circumference. Then what we're going to do is find our Bayesian, or our cross marker FPZ, look your patient straight on, and from that circumference measurement you're going to find 50%. So say your circumference was 60 centimeters, line your 0 up with FPZ and measure 30 centimeters back to cross mark your OZ back here, so you find the true center of the back of the head. Again, we don't eyeball anything except for this one thing on the forehead. Then what you're going to do is find 5% of the circumference. So again, if your circumference was 60 centimeters, I'm making my math really easy here. 10% of 60 is 6. Half of that, or 5%, is 3 centimeters. So from this mark right here, the X on the forehead, you go 3 centimeters one way, 3 centimeters the other way. You do the same thing on the back of the head. From this mark, the OZ, you go 3 centimeters one way, 3 centimeters the other. That's what that says. Next measurement is what's known as your bananas, because these measurements are, they're kind of shaped like a banana when you actually see it on the head. So we just made these marks for FB1, FB2, and the first marks for O1 and O2. So you're going to measure from one to the other, going through that mark you made for C3, and again on the other side. Basically all you're doing here is cutting this measurement in half. So whatever the distance from O1 to FB1 is, cut it in half. That cross marks your C3, because remember we already measured for C3, but on this, when we did this measurement, when we measured along the preauricular plane, same thing on the other side. And then you're going to go halfway again between C3 and FP1 to make your first measurement for F3. Same thing on the other side, halfway between FP2 and C4 for the first measurement for F4. Again, I know this is a lot of like numbers and letters I'm throwing out at you, but I'm going to show you guys how to do it. I'm going to walk you through how to do it several times in lab this week. The important thing is to start learning this head. The more you kind of commit to memory on this head, the easier it's going to go. Because the last measurement that we do is what's known as the horseshoe, which is this little band right here from F7 to F8. It's called the horseshoe because when you see it on an actual person's head, that's what it's shaped like. It doesn't really translate as well in this 2D picture. But what you're going to do is define your marks for F7 and F8. Again, let me find the picture that's got this all. So if we were to divide all of these marks into even segments, which they are, it's 10%, 10%, 10%, 10%, 10%, 10%, 10%, 10%, 10%, 10%, 10%. So if you count all these segments, there's 10 of them. So each one is 10%. You're asking, well, where did the 5% come in? Well, the 5% came in because our first mark for this was halfway. 5% one way, 5% the other, so the total distance between FP1 and FP2 is 10%. So in order to find F7, you're going to measure 10% of the circumference over one way, and then same thing on the other side, 10% of the circumference to the other side. We've already made the marks for these, so you're just going to bend your measuring tape through all these points already, and you're going to, halfway the distance between F7 to F8, mark that. Halfway the distance between F7 to FC is going to cross mark this, F3, and same thing on the other side. The last electrodes that we're going to place are M1 and M2. And again, M1, M2 can also be referred to as A1 and A2. They're named A for auricular because it's behind the ear, not preauricular, which is before the ear. That's the electrode, that's the anatomical landmark. M stands for mastoid, which really refers to the bone over which these electrodes are placed. It's placed over a very inactive electrical site. These are our reference electrodes. M1 is placed behind which ear, left or right? The left ear, because again, anything with an odd number is on the left side, anything with an even number is on the right side. So M2 goes behind the right ear. In addition to the electrode sites that we just, I showed you, kind of quickly walked you through how to measure for, these are some additional electrode sites that are placed for the full standard 21 lead hookup. It's important to memorize this head. It's one of those things that you just have to start committing to memory. I find I draw it out and then I kind of draw my lines, and wherever the lines mix, I know there's electrode sites, and you start filling in the electrode sites and learning all of the different segments and what separates them, because this is going to be a huge component, and you are going to have a quiz on this head. So again, every segment is evenly spaced. If you were to go through around the circumference, count up the segments, there's we'll start here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 segments. So 10 parts of 100 is 10. So each component is worth 10%. When you separate these, they're all worth, each segment is equally spaced, so they're all worth 20% or 25%, sorry. And then don't forget too, when we do the preauricular to preauricular, Nasion to Inion, we measured 10% up to make our first marks, 10% up from the anatomical landmarks. And so you've got to divide those remaining segments equally. All of these equal up to 100%. Same thing on this side. So it's one of those things, you just got to kind of memorize the head. Like I said, you're going to have a quiz on this head. Is it, when did I say? Maybe next week in lab, something like that. But these are the types of questions that'll be on the quiz. You're not going to have a picture of the head. You're going to have to memorize the head. And the questions will be like this. If the distance from FP2 to O2 is 30 centimeters, so FP2 to O2, 30 centimeters, what is the distance from C4 to P4? So again, FP2 to O2 is 30 centimeters, and there's 4 equal segments, so it would be in C4 to P4 is 25% of that. So 25% of 30 is 7.5 centimeters. We'll do the next one together. The measured distance from Nasion to Inion is 32. What's the distance from the Inion to OZ? So let's go back to this head. Nasion to Inion is 32 centimeters, and the distance from Inion to OZ is 10% of that. So 10% of 32 is 3.2. The measured distance from ear to ear, that's another way of saying preauricular to preauricular, is 40. What's the distance from ZZ to C3? So ear to ear is 40 centimeters. The distance from CZ to C3, 20% of that. So got your little measurement there. So 20% of 40. How I do this math in my head is 20% of 40 is 10% is 4. Now I double it, so the answer is 8 centimeters. I do have a little math quiz on Blackboard. You've probably noticed it. It's right on the top of the weekly breakdown. It's credit free. So if you're struggling with the math, because you do not get a calculator, it's math that you're going to have to do in your head, then you can kind of practice going through that minute math, little math quiz that's there. The circumference of the patient's head is 60 centimeters. What's the distance from OZ to O1? So let's go back again to this. So we have circumference is 60 centimeters. OZ is right here to O1, so 5% of 60. What's 5% of 60? 5% of 60. So how I do that math in my head, 10% is 6, half of that is 3. So the answer is 3 centimeters. Which electrode site is half the distance from F8 to FZ? So find F8, FZ, halfway is F4. Which electrode site is half the distance from T3 to T4? So the quiz is going to be a bunch of questions just like that. The important thing is to memorize that head. One of the first things that I did when I took my boards for sleep is I sat down and I drew the head, because you do get a lot of questions like that ask you on the math, that ask you about just the location of the electrode points. So start memorizing that head, because that's what the quiz is all about. If you know the head, you can kind of work your way through it fairly easily. So how to apply the electrodes, the EEG electrodes. Once the correct location of the electrode sites have been located, that's the first thing you're gonna do is just measure the head. You can start to apply the electrodes to the scalp. So the outer layer of your skin contains flat, dry, dead cells that do not conduct electricity well, and the cells can significantly affect the transmission of the EEG signal from the skin to the electrodes. So we have to prepare the electrode sites using some type of electrolyte solution or prep solution. That's where the lemon prep or the new prep come in. They're abrasive. Feel them, they are gritty. The lemon prep is especially gritty. In your kit, it comes in that little orange tube. I do not recommend that you use lemon prep on the scalp itself, because I find it's actually too abrasive. The new prep, which is the green stuff, is a lot more gentle, and I find it works very well on the scalp and on the face. I don't need to be any rougher than how I don't need to use the lemon prep. I think it's just too abrasive. So you need to take care not to over abrade the skin. Don't scrub too hard or too much. We don't want to take the skin off completely. We just want to kind of clean it up a little bit so our electrodes get as good of a contact and conduction as possible. As you continue to practice, you'll figure out how much pressure and prepping of the area needs to be done in order to get a good signal. You can apply that abrasive, the skin prep, via the Q-tip. I find the Q-tip works very well to kind of very specifically clean the spots that I'm applying my electrodes on the scalp and on the face. Sometimes I'll use gauze to clean some bigger areas, like for the EKG and for the legs, but for the skin and for the scalp and for the face, I find I want to be more precise with how and where I clean, so I use the Q-tips. You're going to wipe the electrode site clean. You can either use alcohol, you can use a dry gauze pad, whatever, because you want to make sure that the electrode site is dry before you apply the electrode. Some people will leave the electrolyte on the skin, and it does help get a decent signal, but what you'll find is that tape doesn't stick to wet skin, so you'll have a hard time getting the face electrodes to stick. And the other problem on the scalp is if you leave a lot of electrolyte behind and don't dry it off, it can cause your electrodes to slide, and being accurate with your placement is very important. So I do recommend that you wipe off the electrolyte so that the skin is dry when you go to apply the electrode itself. You're gonna use cup electrodes for your scalp all of the scalp leads. And so you're gonna do a good healthy scoop of the conductive paste, whether you're using Elifix 1020, up to you. And you are going to apply it to the spot that you just cleaned, to the spot that you just prepped. Push it firmly down so the electrode paste comes out that center hole, so you know you don't have any air or anything in between the electrode itself. And then what we're going to do is secure the electrode on the scalp using a piece of tape or gauze. The difference, whether you're using tape or gauze, is whether or not the person has hair. We don't want to tape over hair, so if they have hair, you're going to use a piece of gauze, a small piece of gauze, like the 2x2 squares that have more electrode on it, and that's actually going to hold it in place on the face and on the scalp. If there isn't any hair, we can just secure it with tape, and you're going to plug it into where it needs to go. So the wires are bunches of different colors. Color does not matter as long as where you're applying it corresponds to the correct location to where you're plugging it in. So like your C3 electrode, you apply it in the C3 location, and it's plugged into the C3 port on the head box or the jack box. The paste is water soluble. It does come off in the shower. I tell my patients this. They can try to take it off with a piece of gauze with warm water. I don't take it off for my patients. I find the easiest way is just hop in the shower because, just really saturate it with water. You're gonna want to wear gloves while you're measuring and applying the electrodes, especially on the scalp. You just don't know what you're gonna find in the scalp and in the hair until you get in there. Anything unused needs to get thrown away. Anything you bring into the patient's room is that patient specific. So you want to try to be careful with how much of your materials that you're utilizing. You don't want to have too much extra because then at the end you might have a lot of waste. So being a little precise with knowing exactly what you need so you don't have a ton of waste at the end of your application. And then once we're done using them, we need to scrub them with like the toothbrush, get all the paste actually out of the cup. The warm water helps dissolve the paste out, but it doesn't clean them. You still have to scrub them all, and then you have to disinfect them with like the cleaner wipes that we have back in the lab. Some common issues that are very common throughout sleep and EEG in general for not only measuring and applying the electrodes, but not accurately identifying the landmarks, getting them mixed up with where they are or what they are. You never want to estimate or round your measurements. Try to be as precise as possible. I know the math is probably going to hurt your head at first, but you will get used to it and it will become second nature to you. Make sure you're holding the measuring tape steady to where it needs to be and that you're not letting it slip or slide, because accurate measurements are so important to the accuracy of the test that we're doing. Make sure you actually part the hair. You don't want to measure over hair, especially people that have really fluffy hair. We're trying to find the scalp measurements, not the hair measurements. So we do part the hair to make sure that the measuring tape lies as flat to the scalp as possible. Not consistently marking on one side of the measuring tape. So if your measuring tape is going across and you mark on one side for one measurement and you mark on the other side for the other measurement, you can start to find that your marks and measurements start to deviate. When you apply the electrode, I'll show you a method to make sure that the weight of the wire doesn't pull it, to be able so that it doesn't slide on you and it stays in the position that you want it to, that it's staying precisely where you applied that specific electrode. Same thing with making sure that there's not a lot of stress or heavily tugging on the wires, anything like that. It's going to take some time to learn how to do this, and so I don't recommend rushing. I'd recommend really shooting for accuracy at first, and with time and practice, the efficiency at measuring and applying will come, but focus on being accurate first. And take the time to visually examine and double check your measurements, because you can catch your own mistakes and correct them. And just taking the time to visually inspect. So a lot of errors are very obvious if you just take the time to look at them. Oftentimes, like during your assessments and stuff, I don't even have to come in and remeasure your wires or your electrode points to know if you're really far off or pretty on the mark with where they need to be. So just getting in the habit of visually looking at where your electrodes should be, you'll start to learn when they are accurate or when they start to deviate or are not symmetric, from left side to right side. After the electrodes are applied, take that moment to just visually inspect to see if they are where they are. Moving your hair out of the way takes a couple moments, but it can save you a lot of time later on, especially if you have somebody that's very long hair, very thick hair. And I'll show you a method of how to bundle the hair so that way once you get it out of the way, your lines and where you're measuring and marking are very obvious. One, it's called the ponytail method. You know, up to you if you like to use clips, if you want to use rubber bands, whatever. But basically we're bundling the hair into these little sections so the lines of this, let me scroll back, of this head are very clearly obvious by how you part the hair. It makes it so much easier for applying the electrodes, for visually inspecting them, to be able to see where, if they're symmetric, all of that. And it makes it easier to be able to see if, you know, where your marks are, because sometimes depending on how thick the hair is or how dark the hair is, you can start to lose your marks. And so if you get into the habit of bundling your hair precisely, you won't ever lose where you made your marks. Other issues that you can see, well, that are common with head lead application is that gravity can work against you. If you have a lot of stress or tension on the electrode cup, it can start to, you know, cause it to pull down. So you'll find that the ponytail method is nice because you can use the ponytails to kind of loop the wires over, so it takes off the weight. You don't have the entire weight of the wire pulling down on the electrode itself. What other issues? Be mindful of the direction of the electrode placement. So like last week in lab, we talked about applying the lead wire on the face. Make sure it's not facing down, so it's hanging in front of the patient's face. It goes back up over. Same thing with all the other wires. You want them all facing kind of in the direction in which the wire is going to go. You know, you're essentially going to have like a ponytail of wires coming off the patient's head. And then we're going to gather them all together and secure them with either like it's called a posy or a tie, or you can tie them together with like a gauze pad, because that helps, it helps them stay straight, it helps them from pulling, it helps the patient from getting tangled in them. They're a lot easier, it's a lot easier for the patient to be able to move around with the wires securely bundled together. The other thing too is the wires in and of themselves, if you think of each one as an antenna, when you bundle them together, it keeps them together so they're less likely to be picking up a lot more of the ambient electrical activity in the room. So when you're first starting out with applying and learning how to measure and apply the head leads, take your time. With practice, speed will come. Don't start rushing it right off the bat. Really focus on accuracy first. Hair care products. So all the patients are given instructions to come with their hair clean and dry, free of hair care products, their face free of cosmetics and lotions. Very rarely, fairly rarely do patients actually read that. So same thing for you guys, though. Try not to come with too any hair care products or anything like that, because it really can make the job a little more difficult. So for patients that use hair care products heavily, if you have somebody that spent a long time in the hospital bed, like comatose patients, or you might have patients that just have poor personal hygiene, trying to get good signals really can be a challenge. So alcohol works well, rubbing alcohol either on the small prep pads, or, you know, get a little medicine cup of it, or put some on some gauze pads to be able to saturate and dissolve the electrodes. That's where, I don't know if, you know, the previous slide, when I said wipe the electrolyte off with rubbing alcohol, I would recommend that if you have somebody that's got hair care products or heavy creams or makeups, oh my goodness. The thing with alcohol is if you do saturate your own gauze pad with it from like a bottle, make sure that there's not a lot of excess rubbing alcohol that could drip into the patient's eyes or anything like that. Always warn the patient when you're using it so that they can close their eyes, because you forget how caustic, and it can burn your eyes pretty bad. Just the vapors of it being near your eyes. I would even recommend just grabbing a washcloth and have the patient cover their eyes with it to make sure that it does not get in their eyes. The other thing with rubbing alcohol is be mindful if you're using it on somebody that just shaved. sunburn, all of that. So I used to use rubbing alcohol pretty much standard for every application. But I started to get away from that because you would have people that shave their head right before coming or coming with a sunburn. And so I started to just use rubbing alcohol if I felt it was necessary for overcoming hair care products and that type of thing. You want to make sure that you're gentle, especially when you're trying to get good signals. You don't want to cause any harm to the patient. If you're having trouble getting a good signal, lowering the impedance level good enough, just keep at it. Keep gently prepping it versus prepping it harder. Prep it for longer than, take that top layer of skin off. The electrooculogram electrodes, or the eye electrodes, are placed just outside the corner of the eye or the outer canthus of the eye, and those record our eye movements. E1, which is your left eye, is placed about a centimeter out, centimeter down. E2, which is the right eye, is centimeter out, centimeter up. And those are to display the different movements of the eyes, which is important for blinks while they're awake, slow rolling eye movements when the patient's falling asleep, rapid eye movements when they're in REM. So how you apply pretty much any of the gold cup electrodes, it's the same kind of method. Use that new prep or the skin prep. I wouldn't recommend lemon prep, sensitive part of the face. I would not use something so abrasive as the lemon prep. And I use Q-tips so that because I'm only cleaning a small area. Wipe the skin clean of the prep, and you're going to apply the electrode. Scoop a good healthy scoop and amount of paste, of the electrode paste. Stick it on, and then secure it in place with tape. Be careful when you're taping to avoid not taping over the eyebrows or taping over the really sensitive hairs that are on the hairline or really right too close to the eye. So this is something that's going to take practice figuring out, as you start to learn how to prepare your cart, how big of a tape you want to cut, how big of a tape that you're going to need for that specific area. Some labs do use snap leads for the face instead of gold cups for the same type of stickers that we use to apply the EKGs in the legs. Not really any labs in this area though use that. Most every place uses the gold cups for all of the face electrodes. Electromyography, or the recording of the muscle tone, is monitored on both the chin and the legs. The chin electrodes are placed on the mentalis and submentalis muscles. There are 3 leads total, 2 of which are what are providing the primary signal, and the third one is the one that acts as a backup in case one of the other ones become detached, because these do fall off fairly easily. So the first one is placed on the mentalis muscle, which is about a centimeter above kind of that bottom ridge of the jaw. And then the submentalis is on the bottom of the jaw. So essentially you want to kind of make a 2 centimeter triangle among all of these. So again, chin 1 to chin Z usually provides the primary signal, but say one of these were to fall off, instead of having to go in and wake up the patient digitally, we just re-reference what we're looking at on the computer screen to the 2 electrodes that are still working well. The chin electrodes are one of those ones that you can deviate where you apply them based on the patient's anatomy. So if you have somebody with facial hair, typically you'll find facial hair gets a little lighter right underneath the corners of the mouth. So I'll usually kind of flip my triangle, so to speak, and do 2 right here, and then the third one underneath to kind of make it a little bit easier and go where the facial hair is a little more sparse. Anytime you do deviate from ASM standards, which is this right here, you do have to document why. So how you apply them, same thing as how you apply the eyes. You're going to use your skin prep. I would recommend the new prep, not the lemon prep. Again, the lemon prep is just too rough for the face. Use the Q-tip so that you're very precise in where you're scrubbing for each electrode point. Dry it off and apply the electrodes, and remember the electrodes, good healthy scoop of paste, and then you're going to secure them in place using tape. However, if you do have somebody with a beard, remember we don't tape over hair. So if you do have somebody with a really thick beard, What you're going to do instead of tape is use gauze, just like how you apply the head electrodes. You're going to use gauze with a little extra paste on it to hold these electrodes in place. We use gold cup electrodes generally for most instances for the chin, but if the patient has a beard or excessive facial hair, the gold cup electrodes have to be used in place of the snap leads, because the snap leads, remember, are like stickers. So if somebody has really thick hair, you're not going to put tape or stickers in their hair. So gold cups have to be used if the patient has a lot of facial hair or a beard. Snaps can be used if the person is clean shaven. So there's 6 electrodes total that go on the face, the 2 on either side of the eyes, the 3 on the chin, and then 1 on the middle of the forehead for the ground. They're all placed with the gold cup electrodes, and generally we're using tape for all of these electrodes, unless if you have somebody that's got heavy facial hair, you're using gauze for the chin. Use caution if your patient really has sensitive skin, like if they're older, younger, and just the face in general can be quite sensitive, so don't over abrade them. All the tape that we use is hypoallergenic and skin sensitive, so make sure you're using the appropriate tape. There are tapes out there, there are medical grade tapes that are not meant to be on the skin though, so you have to pay attention to that. And the biggest thing too is make sure you're being really careful when you're taking the tape off, because that can really cause a lot of irritation for our patients. The leg electrodes, or leg electromyography, are placed on the anterior tibialis muscle. How you can find that muscle is it pretty much runs parallel to the shin bone, just to the outside of the shin bone. Have the patient point and flex their foot at the ankle and feel for that muscle, but just know pointing and flexing the foot will cause the activation of a number of muscles, not just the anterior tibialis. So another way to do it is just have them wiggle their toes, and that muscle is a little more isolated when you do it that way. 2 electrodes are applied to each leg. You're going to place them longitudinally, so they're vertically apart. You're not going to go like one next to the other. They're longitudinally, like just look at where the muscle is. You're going to put one here and one here. You're not going to go side by side. They're going to go up and down. And you want them to be about 2 to 3 centimeters apart. The stickers that come in your kit will kind of dictate how close they can be, because those are really big stickers. So you want them trying to be about right in the middle of the muscle, so middle of the leg, not too close to the knee, not too close to the ankle, right in the middle of the leg, right in the middle of the muscle. And then you're going to put them on. What you can do is tape over the electrodes as well. For practicing in the lab, I generally don't have you guys tape, because it's just more you're going to have to rip off of each other. But for the overnights, I do place a piece of tape over those electrodes to make sure that they're secure there. These are the ones that probably get kicked off the easiest throughout the night. Application, same way how we're applying everything else. Clean the spot with a little abrasive. This, you can use the lemon prep. It's not nearly as sensitive of an area, and it's harder to get a good electrode signal because of the distance and the length of the wires. So you do have to scrub a little bit harder for these. So you can use the lemon prep. Wipe it off. You can wipe it off with a clean dry gauze pad or an alcohol prep pad, so that the site is dry. Because again, it's tape, adhesive, stickers, they don't stick to wet skin. And then you're going to apply the patch with the electrode to each site. Again, don't forget our snap stickers work so much better when we add a little extra electrolyte to the center of the sticker, to that little gel area of the sticker. It pretty much rehydrates the stickers if they've dried out or anything like that. You're going to secure it with tape or a stress loop. So what a stress loop is you just want to make sure that the patient, there's enough slack here that when the patient stands up, these wires don't pull tight. And so a stress loop is you're kind of creating an extra loop and securing it. So if the patient was to move around and all this, and the wires were to tighten, hopefully it doesn't unsnap it from the stickers, which has happened before, but instead it pulls from the extra loop. So with these electrodes, the stress loop, I've never done it. I find that I just make sure they have enough slack that it doesn't cause tension on the wires, but just not enough that they can trip on it. You know, make sure it's not so low that the patient can trip on it, because that would be a safety hazard. Your ECG or EKG, electrocardiogram, we use a 2 to 3 lead depending on the system and the lab that you're at. The electrodes are placed. The first one is placed on the right side below the right clavicle, and then the second one is placed on the lower rib cage vertically aligned with the left hip. So it's basically right on the side underneath the patient's arm. Again, I'm not having you guys lift each other's shirts to apply this second lead. So for the purpose of practicing in the lab, you're going to just apply your second EKG on the left side underneath the left clavicle, basically where you would apply the third lead for a 3-lead EKG. Application, same thing, have how you've been applying. You can use the lemon prep for this. Just be a little more careful in how you were on the legs, but you can use it. Up to you. Got to practice, see what works best for you. Clean the spot, dry it off, apply the snap stickers. I find having the stickers already attached to the lead is a lot more easier to apply than putting the stickers on and then attaching the wire to the sticker itself after it's on the patient, but you'll figure that one out on your own as well. The snore sensor, essentially, remember, we don't have to prep the skin to apply this because it's just picking up vibration. It's not picking up the electrical conductivity of a muscle or of the brain waves or anything of an area of the brain. It's just picking up vibration. So all you're going to do is figure out what size tape you want and kind of create a sticker with the snore sensor, feel the patient's neck and have them either cough or say something while you're feeling for the vibrations, and place it where you feel the vibrations are the strongest. For this one, I take care to avoid the artery, the carotid arteries, because if you place that snore sensor right over the artery, you're going to get a lot of the bounce from the artery versus actual snore. Always use skin sensitive tape for this one, and I always also actually use the adhesive remover to take it off, regardless of whether or not the patient has sensitive skin or not, because the neck is just very sensitive skin on most every person. It doesn't matter what side of the neck that you put this one on either, but I always take care to put it on whatever side I kind of am bringing all my wires to. So you guys remember in the lab when we started applying the body wires, all the wires tended to come to one side, and that makes it easier to bundle them together so they're more secure, patients less likely to trip on them or get tangled up in them. So I just bring this one to whatever side I already have all the wires on anyway. I just answered that question for you. So we don't apply it directly on the carotid artery because it's going to cause a lot of bounce from artifact from that artery versus picking up the actual snore. The tape, the skin on the neck is very sensitive, so be very careful when you're taking this one off. Luckily, the tape that comes in your kits and the tape that most labs use is a cloth tape, which means that you can saturate it. You can saturate it with rubbing alcohol or adhesive remover, and it'll help that tape come off very easily. Sometimes you might find, and I've found this a lot in previous years, that students have trouble getting the snore sensor, the tape, to stick to the neck. And it could be because we all put, or not we all, but a lot of people use lotion on their necks, things like that. So if you are having trouble getting the tape to stick to the neck, because remember, this is not an area that we actually prep. This is one of the few electrodes that we don't actually have to prep the skin for. You might find that just, cleaning the area a little bit with rubbing alcohol will help your tape stick to the neck if you're having trouble getting the tape to stick. And it would just remove any skin oils and anything that might be on the skin that might prevent that tape from getting a good adhesion. Pulse oximeter is the little sensor that goes on your finger. We've covered, I think this is the 4th time I've covered it, so I'm not going to really say too much about it. It goes on any of the 3 middle fingers of the hand. Sometimes though, especially if you're dealing with somebody that's very petite, I find sometimes I get a better signal when I put it on the thumb. You want to make sure the red light is aligned, going so it goes directly through the fingertip, and then we just tape it in place, because for the most part for the overnight we're not using these hard plastic oximeters. We use these soft ones that we have to tape into place. Just makes it more comfortable for the patient. Nail polish, fake nails, they all can interfere with that light being able to pass through the finger from one side of the probe to the other. So it can give us these wonky readings with the SAT probe. So pay attention to that. If possible, take off the nail polish, or have to see if the patient can take off the fake nails, if they can be removed. If it's not possible, I know some labs will cancel the study. They won't do studies on patients that have like the shellac nails or anything like that. Patients have to come back after they've been removed. And this is all stuff that the patients are prepped on ahead of time. So when they show up and they have the fake nails and they have the nail polish, it's just showing that there was a lack of them actually reading the instructions. The airflow sensors are placed just below the nose, the nares, the nostrils, and then there's generally a little piece that kind of hangs in front of the mouth. It doesn't go in the mouth, it just hangs just in front of the mouth. The wires kind of go back around the ears, and then there's a little piece that will cinch in place. So they go just in front of the nose, around behind the ears, and come back towards the front, and then you're going to kind of cinch it in place. What you're going to want to do is secure it with tape. So I usually take 2 pieces of tape and just tape it on the chin here, or on the cheek here, and the cheek here, and that keeps the flow sensors in place for where I want it to be. This is one of the few sensors that we do have to give the patient instructions on what we expect from them. They really need to try to keep the sensors dry. So if they're going to blow their nose or get something to drink, I tell them to just lift this up and set it on the bridge of their nose, get it out of the way. Most labs now are smoke-free facilities. Pretty much all hospitals are smoke-free campuses, so patients cannot smoke. You might still come across like a private lab that allows the patients to go outside to smoke with all the equipment on. That's becoming fewer and farther between. But if they were to smoke, that's one of the ones that they cannot exhale their smoke onto the sensors. They either have to take this off completely, or I tell them lift it up, set it on the bridge of your nose, get it out of the way. But again, luckily that's something that we're coming across fewer and fewer and fewer. The belts go around the chest and the abdomen to monitor the airflow effort. You want them snug, but not too snug. Make sure that the any slack that you have is secure. You don't have like these loops hanging off the patient. You want to put the chest belt kind of just underneath the armpits, right around the chest. The abdominal belt is going to go right around near the belly button. They go outside of the patient's clothes because they're rougher material and we don't want them rubbing against their skin, and it's just more hygienic that way too. You will get patients that will try to, I never sleep with a shirt, I can't sleep with a shirt, and then I always just play up how rough the belts are. You need to wear a shirt so they don't rub against your skin. They're not too rough, but it's so much more hygienic when the patient wears a shirt. Our electrode application really does determine the quality and accuracy of the recording that we're doing. So it's so important to focus and work on the skills necessary to be able to do a good quality electrode application. How we measure the quality of the application is by measuring the impedance level, and the impedance is another term for the measurement of the resistance in the electrical circuit. The definition of resistance is just the degree to which the object opposes or resists the electrical current. So essentially, think of it that when we're prepping the skin, we're getting rid of dead, dry skin, physiological matter that could impede the electrical signal from the brain or the muscle or whatever we're trying to record, and it blocks that electrical signal from from reaching the wire, which will then travels to our system. So by scrubbing well and by just eliminating whatever we can, the electrical signal is able to travel much more easier and clearer from the patient to our recording system. That's why we measure our impedance levels. It's essentially measuring the resistance, how well we were able to prep the skin and prep the areas that we're applying the electrodes to get a good signal. So the better your impedance levels, the lower they are, the better quality of your signals. As you continue to practice, what I'll have you do is start practicing with the computer and learn how to check your actual impedance levels, because knowing how to check them and then knowing how to fix them, recognizing which ones need to be fixed, that's all a skill that you need to start being able to pick up on, because that's part of your assessments and it's a huge part of just ultimately your career in sleep. So you're going to check your impedance levels after applying the electrodes. You want the impedances for your eyes, for your head wires, all to be less than 5,000 ohms or 5 kilo ohms. Anything that is higher than 5 really should be removed, reapplied, recleaned. And there's a lot of different reasons why your electrodes could have high impedances. Either you didn't scrub well enough, you didn't use enough paste, the electrode isn't pushed all the way down, so maybe, some of you remember when we were practicing in lab, it came through and pushed the electrode down even more on the skin. So if you don't push it so it's flush against the skin, it can cause some difficulty with the signal. So there's a lot of different reasons, and it just comes down to practicing to develop those electrode application skills. So we've covered a lot of this already in lab. I'm going to leave these last questions for you to do and look up the answers on your own. What muscle are the leg EMG electrodes placed over? What type of wire is best for recording EEG activity? Where should the chin EMG electrodes be placed? On what muscles are the chin EMGs placed? What are the recommended impedance levels for EEG electrodes?